now live. Okay.
Good evening, ladies and gentlemen, and to everyone who's joined us for this very interesting live webinar. My name is Ruben Lobo. I am your host, your friend, your moderator for this evening. And together, let's make this evening as the most memorable evening for everyone who's present here. I say that because of a very special speaker that we have in our midst. It's such an honor to have Dr. Norman Kwan, all the way from Canada, who's going to express, who's going to share his expertise, his knowledge, his wisdom from the 3 decades of the overwhelming practice that he's had. Ladies and gentlemen, I hope you all have been doing well and you're keeping safe from wherever you have joined us. Namaste to everyone who's joined us from India. A warm good morning to everyone who's joined us from Canada, and of course, a very warm welcome to everyone who's joined us from various parts of the globe. Ladies and gentlemen, once again, it's such an honor, like I mentioned, to have Dr. Norman. I say that because of the feathers that his cap has. He's an educator, an entrepreneur, a scientist, a researcher, and of course, there's so much that I would forget to let you know the kind of work that he's been doing in this discipline. Such a pleasure to introduce Dr. Norman to everyone who's watching us live. Dr. Norman Kwan obtained his Masters of Science from the University of Toronto in the year 1977 and his Doctor of Dental Surgery from the University of Toronto in the year 1982. He is licensed by the Royal College of Dental Surgeons in Ontario. Dr. Kwan received his postgraduate training in implant dentistry in the year 1987 at the Lund University in Sweden. Later, he went on to pursue a course from Harvard University in Boston in the year 1987 to 1989 and the Brookdale Hospital Medical Center based in New York in the year 1989 to 1990. Dr. Kwan is a diplomate of the American Board of Oral Implantology, Implant Dentistry, the International Congress of Oral Implantologists, and the American Society of Implant Dentistry. He is currently a member of the medical staff of the Niagara Health System, as well as the Healthcare Corporation of St. John's, Newfoundland. Presently, he is the executive director of the Canadian Dental Implant Institute and founder and CEO of the Biomedical Implant Technology. Since the year 1993, Dr. Kwan has developed numerous implant educational training programs. Dr. Kwan is a regularly invited speaker at many United States of America and international dental conferences that take place all across the globe. He is also the inventor and the developer of the BioHex one-piece, one-stage dental implant systems. And he also holds numerous US and international patents. For the last 10 years, his research has been only focused, rather it's been exclusive in implant prosthetics. Without much further ado, may I have the opportunity to present to you Dr. Norman Kwan live on a very interesting topic, restoration of an edentulous maxilla. Ladies and gentlemen, presenting to you Dr. Norman Kwan live.
Okay. Thank you. Thank you, Ruben, for a very, very impressive introduction. And that it was a pleasure to be here after all these years of research and development of really trying to make dental implant easier to do and also more predictable, so we can keep the money that we make from delivering this wonderful treatment for our patients. So let me just start the presentation by sharing my screen here. So it's here. So is everything okay? Can you see my screen? Okay.
Yes.
Okay. So let me just start by going back to the by Albert Einstein's quote. Basically, I came to realize this when I was trying to solve a lot of the dental implant problems that I have in my clinic. By forever trying to use maybe an abutment, different abutment, longer, shorter, different shape, and try to solve the thing that I have experienced. So after 35 years of implant dentistry, I come to the following conclusion, that when you do dental implant, you will have failures, implant failures mostly, in spite of the 90–95% success rate that people are claiming. But you do have problems. And also, another problem that you will have through the course of your practice it will be the prosthetic complications, screw loosening, fractures, teeth fractures, and all that. So I come to also the conclusion that the solution for all these problems, dealing with it, is from the very start that you try to minimize this occurrence, the failures, minimize it. But things do happen, and then when you do have this thing, complications, failures, that you have to manage it in a way that is simple and not causing too much stress for yourself and the patient. So it's based on that two ideas, I'm hoping to share what I have done for the last 30 years. Just briefly, when I graduated, I spent the first 5–10 years in trying to understand more about dental implant, because we were never taught dental implant in dental school. As a matter of fact, when I graduated, that was the time that Dr. Branham come over to Toronto, to the University of Toronto, and start presenting the first conference of osseoid integration. I was there and get so fired up and interested in that discipline. Then after 5 years of getting all the qualification, I understand there's severe shortcomings applying this concept of osseointegration into dentistry, and specifically dental implant in dentistry. So I spent the next 10 years trying to research and develop different prototypes until 2000, and that I think, I have some prototype that I can use. It seems to make sense to me. And then for the next 20 years, now to 2020, that I've been using that component over and over again, from single tooth for all the treatment scenario that you will face in your clinic. So briefly, that's what it's saying. So again, as I deal with the clinical implant dentistry every day, I come to the conclusion whether the dental concept can be applied effectively for dental implant treatment, or simply using osseo-integrated implant to support your teeth, the prosthesis. Then those questions start to come is, why does the abutment need to look like teeth? The implant abutment have nothing to do with natural dentition. And why do we always make them long and parallel, similar to the dental concept? And by using those different components, different abutments, all these different parts that created thousands of them in one system, and also the corresponding prosthesis is equally complicated. So those are the thing I start to question the current concept and product, whether it even makes sense, as if we are because the implant that we place into the jawbone are at a different angle than the teeth. So forever we'll try to, let of a better terms, fitting a square through a circle and try to make them fit. So 20 years ago, I come up with this idea of why do we standardize the abutment? Because we are no longer dealing with teeth, and therefore we do not need to look like a prep or abutment crown prep, long and narrow and conical. Rather than we improve, because it's a mechanical device, a mechanical medical device, why don't we design the support of it into a very robust, like a nut in a wheel, a hexagonal shaped nut. And then also develop a matching component, which I will share with you later. And then I stick with that two component for the last 20 years or 25 years, over and over again, basically to clinically validate this process is safe, effective, and simple and predictable. If not, then I will be able to make changes to make changes as I go along, because so let me just, without going into the detail, I just want bring your attention to basically it's the hex that we are dealing with, and also by simply modifying the hex by removing one side, two sides, three sides, and realizing that the retention of it is still fairly substantial when compared to the traditional abutment preparation. Okay, you just have to realize this can be done and effectively as mechanically for retention and resistance. So, and then we sort of did some experiment to say, if you have prepared the implant abutment the same as the dental concept, then it needs to be 3 times as long, because you do not have that mechanical advantage that or geometric advantage of a hexagonal shaped abutment. So by being a shorter of 3 times or 1/3 the length of it, that allows you retain the mechanical retention, you maintain it, or improve by 3 times, I guess, if you want to put it that way. And then the fact that it's so short that you basically are more forgiving. So the range of error, because it's so short, then so you can restore a lot of cases for a single tooth replacement. So that was for single tooth, how we deal with it. But for multiple implant, we know that in spite of how careful you are with whatever digital technology, scanning, CT scanning you use, you can never try to line them up. So the next logical thing is to find different abutments and try to make them parallel, like dental concept. But then again, when we researching all this on the bench, we discovered that, let's take a look at the bottom the bottom slide, is that when you have 2 implants at a different trajectory, if you try to establish a common path of insertion, then when you analyze it, only one part, looking at the, I don't know if you can see my pointer here. Ruben, can you see my pointer?
Yes, doctor.
Okay, good. So I'll just point instead of try to verbally describe the picture. So when you have a common path of insertion for the both implant, only one side of it is obstructing. Then you can either simply remove that in the mouth, and then you can have your splinted prosthesis, Okay, let me just demonstrate you with the physical picture here. So you have 3 implants at different trajectory. So if you splint it at the restorative component, which is a plastic with internal hex, matching the hexagonal shaped abutment. When you analyze it, only one side of the abutment is obstructing to the prosthesis or to the, let's call it a castable healing ball or healing balls. Okay. Then once you remove that, the hex, then the whole framework can be inserted passively into the 3 implants. So basically, you remove this part and this part and this part, one side of each abutment only, never on both sides, because the other side is matching or engaging the part, the hex of the unobstructed part of it. Okay, let me just show you a video. If you identify the obstruction and then remove it in the mouth, then, so we, after healing, we place the healing cap or the impression coping to the abutment, and we glued them together in the mouth. Okay, and then you can see the undercut or the obstruction to that is on this side, which I will show you. You cannot go back in. Okay, and then here and here, after you remove the obstruction, this is our path of insertion, then you can insert the prosthesis. Okay, this is the cast of the a metal framework or from that healing ball coping framework. Very simple concept. Very simple concept. Remove the obstruction, insert it, and then it will give you all the retention resistance. So as we develop this concept, we realize from the natural stack of the current implant concept, you have the crown, the abutment, and the implant in these pieces. Now, if you have a splinted coping like what we had in the other previous slide, and then if you use this one, the right implant axis as your path of insertion, then when you want to insert into the other one, you can actually remove, like in the other picture, the position B. Then you can insert your implant or your prosthesis. Then you will only have no obstruction. Alternatively, you can remove the coping. Once you remove that obstruction, then you can again insert your prosthesis. Again, when you secure the whole part of it, if you can also reduce C, the opposite side of B, because that will be the only side obstructing, or alternatively, you can remove part of the implant, which is D. Okay, let me explain it by the different thing. So again, we have the implant, we have the abutment. If you can establish this common path of insertion by marrying this abutment to B, then you basically have a one-piece implant, or you can put your screw down your abutment to the implant and have the B part removed. Then you will have a tissue level type of arrangement for the insertion of your splinter prosthesis. Now, if you married your abutment to the prosthesis, then the obstruction will become on the bottom of that one-piece implant and abutment unit. And again, when you insert this one, then you are basically removing the obstruction for the insertion to the two implant. And then that becomes effectively a bone level restoration. So the whole idea really is try to minimize your part or your moving parts into either the implant or the prosthesis or the abutment implant, one piece implant with the prosthesis alone, two component only with nothing in between and screwed down by the abutment screw. I know this is the concept is simple, but it's complicated because it involves multiple level of opposite thinking. But anyway, so people usually really raise a lot of objections about touching the implant because they're sacred. So, but then again, I bought an Astra implant that they seem to be doing it now, but nobody have ever put the whole thing into one picture and look at it logically. Okay, so, but anyway, this is just briefly concept. So 1993, I started this company, not because I want to start selling implant, because my job is just a dentist and that making my living from dentistry or specifically implant dentistry rather than a sales guy, a salesman, try to promote the implant. But so I have to establish this company in order to legally develop, research and develop components and place it in patient in a clinical setting and follow them for 20 or whatever years that I need to follow. So I need to be legal. In other words, I have to establish a company, have the regulatory approval for all my products before I can use it in patients. So that's the reason I started this company. So, but now I think after 20 years, I think we have we cover all the complications, see how they perform over long term. And I think we are ready to share our concept and products so people can try it or benefit from it. So basically, as an overview, I have three technology. One is the one-piece implant, basically marrying a standard abutment to the implant. And that become a one piece. So all you have to deal with is the obstruction on the B part, and then to deal with the coping. So after that, I was trying to see, can this method be done with the two-piece implant? Meaning that, can I marry the abutment instead of to the implant? Can I marry it to the prosthesis, and therefore the reverse BioHex, or I call it the Kwan implant. And lastly, the thing is, for people who are using different implant like the internal hex, 2.4 millimeter internal hex, the conical abutment connection, can people using different connection apply or benefit from this concept? So and then we developed this multifunctional abutment for all implants. I'll try to give you an overall view of all that before I would just show you clinical case about Edentulous maxilla. So we started 1993 by choosing a bronze implant with external hex. And then from that prototype, we decided on one hexagonal shaped abutment, as I showed you previously, and that pre-assemble it in the factory as assembled. So when we put it in, instead of just putting the implant itself, we put in the healing abutment at the same time. In this case, the hexagonal abutment used as a healing abutment. And they work the same. There's no difference in terms of success rate and stuff. But remember, those are about 25 years ago when people, we're still fighting is 4-6 alloy better or worse than the pure titanium and all these different things. So after doing 5 years of using the 3-piece hexagonal shape abutment, I think with that concept that I share with you, I can restore all cases with from single tooth to a full arch, upper and lower. If you want teeth replacement with implant, then I can basically use the same support or abutment for all the cases. And so with that idea, I remove all the component and make it simple into a one piece. It's stronger, it's simpler, and there's no moving target, meaning that whatever you put into the jawbone is there. There's a lot of advantage to it. After 30 years, I still stand by the one piece, because without the connection, the gap, the micro gap, that eliminate a lot of problems clinically and long term, which I can address to it if people are interested. So basically, the product in 1995 we developed is the same as now, no difference. Double vials with a sterile implant on the second vial, and then you can do a carrier, or you can engage it in the hex and use it as driver and drive the implant into the bone. And meanwhile, that if we know that that this gonna be our abutment, so I, instead of trying to make a new margin or something, I machine the margin there and surgically place that margin the way I want it. Okay, so basically for the last 25 years, I have used what is on the screen now, the implant, but I do require a smaller implant for lateral incisor or the mandible incisor. I do need a smaller profile for restoration. But basically, we have a corresponding analog and the restorative component and the guide pin to secure the restorative component. And after restoration, we use the retaining screw to secure that coping. So immediately we remove about 2,900 or something of the catalog that people are doing what abutment to use. So no, the abutment is there. So let me go to that was basically the one-piece implant. The second, then the next question I ask, can the BioHex concept apply to the two-piece implant? So when you look at the underside of it, let me just share with you a 2-minute videos that will explain it.
Kwan implant restoration. The Kwan implant restoration concept involves placement of implants in their natural root positions and trajectories. After the appropriate numbers of implants are placed into their previous tooth or root positions, a corresponding scannable healing abutment is attached to the implant for proper healing and soft tissue profiling. With a non-contact intraoral 3-dimension scanner, an accurate virtual model can be generated on screen. Using any computer-aided design dental software, the final one-piece restoration implant can be created. An implant trajectory was chosen as the path of insertion for the dental prosthesis. All other implants would have a different trajectory to this insertion path. In order to create a common path of insertion for the dental prosthesis into all the implants, the obstruction of the abutment posts needs to be removed. Please note that only one side or 3 of the 6 surfaces of the abutment hex post is obstructing, never on both sides. During normal occlusion, lower teeth exert their forces on the cingulums and lingual cusps of the upper teeth. The labial side of the implants and abutments are resisting these biting forces. Please note there is no force acting on the lingual side of the hex. This clinically validated method provides a stable attachment of a one-piece implant prosthesis to multiple implants with different trajectories, without any intermediate components between the implants and the final restoration. The computer-aided design dental prosthesis can be fabricated directly from milling block of materials, including titanium, zirconia, and other tooth-like materials. After milling of the restoration, it can be aesthetically enhanced with customized porcelain. The final prosthesis can be directly inserted into the implants without any further steps. The prosthesis is stabilized by 2 set screws, as the forces from occlusion are directed to the apex superiorly and laterally, but not in the opposing direction. The Kwan implant restoration method allows the fabrication and insertion of a one-piece implant prosthesis in one single step after implantation. Kwan implant restoration.
Okay. So basically with that, we can, this is a summary of basically how we can apply the reverse BioHex in a clinical sense. So let me validate this thing with some video. I want to share a video thing here. Hang on, let me just go in and share it. Now this is an 8 implant. It's specifically, I think, is the BioHex. Not Simmer. It is the Dr. Nisnik's internal hex implant. 8 implant were placed in the maxilla. When most of the restoration is usually the problem. So you can try to line them up with different abutment, try to make them parallel and all that. It become a very labor intensive and unpredictable from my point of view. And also it's difficult to deal with complication. Either it's screw loosening or fracture or implant fail. Try to remove that, you might as well. You lost all the profit from that case. If you have to deal with any complication, which it will happen, and therefore, so using the reverse BioHex concept, you can actually okay, those are the 8 implants in different trajectories, and then using this is the CAD/CAM mill one, okay? So you can see the abutment was reduced using a computer model, and they are very, very retentive, even at this thing. Okay, and so the top part of the abutment is married to the prosthesis or embedded in it. So you don't have to deal with it. And all you have to deal with is the bottom part of the attachment. And then and that become your one-step process without any intermediate component. And if you want, you can actually put a screw in, any screw. Okay, and then you can see how retentive they are. When you turn it upside down, there is no, it won't fall off. And that during function, you know that it will be stable. Now, if the one of the implant fail or two implant fail over time, hopefully it's not the both sides at the same time. If they do, all you have to do is unscrew the prosthesis, unscrew it, remove it, do your modification, close it off, remove the implant, and cut the pontic if they're too long, or leave it in. So that's what I mean. Try to plan it so you have more implant, and that having a screw retain one piece prosthesis, then you can manage the complication better. That's basically what I mean by let me go back to the other. Okay, so that's basically a bench demonstration of the reverse BioHex concept when people are using whatever implant they're using, mostly a two-stage. And I understand you guys will have ceramic implant coming up very soon, and I was really excited to see it. But that ceramic implant, be it two piece or one piece, can use this restorative method very effectively. But it takes time to change minds. So the third one, since the reverse BioHex works so well for the two-stage system, so my thinking is that can I apply the restorative concept to all the implants that people are using, like conical, Noble BioCare, the tri-loop, or whatever heck connections configuration they come up with. And then, so the beauty of it is that by using the hex as a restorative adapter, you can eliminate all this cover screw healing abutment, transfer coping, transitional abutment tissue, or you can use the same one hex into multiple things. In other words, you do not need to remove for your healing abutment, for your transfer coping, and then reattach transitional abutment different type. It will drive you crazy if the patient have to come back so many times. Basically, what you have to do after you place the implant, whatever implant you're using, you attach the corresponding adapter to your implant as a healing abutment, and then you can start scanning or use it to transfer your coping using the healing ball, and we will provide you with the prosthesis that will fit into your implant after you remove the adapter from the implant when you receive the final prosthesis. Okay, that is the idea. So basically what we are trying to do now is try to standardize all the abutment with different type of connections, be it Noble BioCare, Strongman, and escape me the name of this internal hex, Dr. Nisnik's company, and the BioHex, and the Biomax 3i. Basically, this restorative concept can apply to all implants. And since I started to next year, and this is my first seminar, so I want to make it affordable for everybody. So I just basically, at cost, because my job is not to make money from dentistry, from you. I make money from dentistry and from my patient. And so I basically put an introductory price at cost, which I have to fight like crazy with my my group to put it into something US dollars, and anyway, into something that might get people to benefit. Instead of doing few implant, you do more, because 1 and 10 implant, basically the time is only incremental, but the safety, the redundancy you build into your plan will be that much more because everybody knows surgically placed implant is a matter of minutes. But when you have complication, to have that backup more implant, then it is really beneficial for the dentist and value for the patient. And that's basically the. It's no good when only 10% of the population can afford it. I want hopefully another 40% of the people can afford it. Basically, should be cheaper to replace your natural dentition with dental implants. That's my hope. Okay, so this is basically the first part overview of my share. Is going to stop as is closed. Okay, let me share. Please, any question before I go to my second presentation, which is a clinical case. Anybody? Okay, well, let me go there. Is the screen okay?
Not yet.
How about now?
No, not yet, sir.
Okay, so I need to reshare it, right? Basic. Let me go to basic, and then share. How about now?
Perfect. Thank you.
Yeah, it's okay.
Yes.
Okay, good. So this concept, I started really without knowing that can evolve into a concept. It just makes sense for me in 1996. So basically what I did was that prototype, a hexagonal shaped abutment, which I developed, and hopefully that I want to use it as a standardized abutment. I pre-attach it to the Bronama implant, and place it into the osteotomy at the same time, the healing abutment. And then also I use it for my treatment planning. Like, please remember, this is 1996. At that time, I religiously follow the commandments, like treatment planning, like surgical guide. I really religiously follow them and do just. So I place, instead of, nobody cares about the position of the implant, but they do care about the position of the abutment. Now that the abutment is visible, that I can plan it. So the job is try to, on the model, do my treatment planning, place the abutment, 8 implant to the incisor, the cuspid, and the posterior support. And then I developed, I was very proud to develop that surgical guide for it. And that during placement, I tried to follow the surgical guide. And then after doing a lot of this, I find that as a dentist, I should know where 1-1, the central incise, the right central incisor 1-1 is, and 2-1, and 2-3, and 1-3. I should, without even having a guide. And when I look at it, I can see, I should be able to see the frenum, the nasal spine, anterior nasal spine, and then surely the 1-1 should be here, and 2-1 should be there, and 2-3 there, and said, why do I need somebody to tell me, since I don't really need to worry about the trajectory anymore? In other words, I do not need to make them parallel. I'll just go in where the bones are, like they always say, and then place an abutment where 1-1 is, 2-1 is. So, but we can talk about it more in the following seminar. So, but 1996, 1 stage and 2 stage are very controversial, but clinically, I see no difference. And so we did a study 5 years prior to that. And if 1 stage heal, 2 stage heal properly, 1 stage heal as well. So I just suture and use the hexagonal shape abutment as a healing abutment. And then after they heal, that we expand the attached gingiva with our healing ball to make it bigger. To allow me to put another healing, to use another healing ball, match internal hex, matching each hex. Okay, and lute them together and then take an overall impression. Okay, now the reason why they work is that the abutment length or height is not 5-6 millimeters, it's only 3 millimeters. So when you look at it, if you have different angle at a very short height, then the one across or the obstruction is not so much of an issue with pliable non-metal type of castable coping. Okay, so you can remove it basically without damaging it. So this is the underside of the impression, or the healing ball framework is picked up by a wash type of impression, where the timing of each and every abutment relationship is captured at the same time. It's very important. It's very accurate. If when you try to insert 8 unit of abutment, or 10 or 5 or even 2, if they are not if the geometry is not correct, then you will bind. You cannot seat the prosthesis. Okay, but with this method, it's almost foolproof. So 1996, those abutments, and that selectively we remove the obstruction on the abutment. But at that stage, we are still using the 3-piece implant because we do not have a system yet. So with that healing ball framework, we wax up the framework because they're castable. And after the casting, then we will have a framework, a screw retained framework, meeting all the abutments, margins, okay? And then 1996, because there was a lot of issues about porcelain, whether it is good for the implant and natural teeth because they are hard. So we start using a plastic isocyst material that are bonded to the process onto the metal framework. But after a couple of years, we realized that the complication of the fractures of that particular material is not very stable, and we have to deal with it on a very frequent basis. And then after that, we decided we need to go back to the well-tried concept of porcelain. Okay. The bottom one was done the traditional Brahma, the high water design, which works very well as well, you know. But for partial and edentulous, full edentulous, the telescoping type provide a lot more advantage, like aesthetic, hygiene, speech, phonetics. They are very important, especially for the maxillary type of restoration. Okay, so that case was finished in July of 1996. And then we follow up with the patient religiously every year. We ask them to come back to measure the bone and all that. Okay, so after 10 years, the patient come back, and she was 65 when she started, and that it was 80. She was 83 years old when she came back, 13 years afterwards, and with a lot of complications on the prosthetic of it. Okay, so we removed clean it up, and then we inserted it after 13 years. And she had a stroke. The reason why she did not clean her teeth well, she had a stroke, and that was in a nursing home. So this is after the cleaning, after 13 years. Okay, 1996, she came in for the treatment, and 2008, she had a stroke and came in. So let me just share the last video that I had with her. After remove the 4 retaining screws, I removed the prosthesis and cleaning it up. I put some sealer, polyvinyl siloxane material, to seal out the void inside the coping to make it, and then we
white and then everything. Yeah, good. Okay, good. You have a good. I'll see you maybe another year, I think. Okay. Good.
Okay, Ruben, I think just an overview of our first seminar. I was just wondering if there are any questions.
Yes, doctor, we do have questions.
Yeah, good.
Yeah, I wanted to know if you've completed from your end.
Say again.
Yeah, I wanted to know if you have finished with
yes,
your
yeah. There's a lot of material. I just really briefly going through it with saying, but certainly there are a lot of. I expected there will be question because it's a little different approach than what we normally do for dental implant.
All right. So thank you so much, Dr. Kwan. I think before we move to the question and answer session, I'd like to thank you on behalf of DentistChannel.Online for coming and gracing this event. It was so nice to hear you. I know you have 30 years of experience, and I think it's going to take you 30 hours, and I'm sure you'll be with us for many more presentations. Before I make the good announcement and the happy news to people, I'd like to thank you, and thank you so much, Dr. Kwan. It was a pleasure and a privilege to have you, to be very honest with you. Friends, thank you so much for joining us. It's time for us for a question and answer session. Before the question and answer session, ladies and gentlemen, I'd like to tell you that Dr. Kwan will be with us every month, once in a month, starting from the next month. We're starting with a great learning program, which will be absolutely free of cost. We'll be starting probably from the 7th of January. We are yet to finalize the dates with Dr. Kwan. Dr. Kwan and his team has been very kind enough in giving us his time. He's going to share his wonderful experience on a topic titled what not to do in implant dentistry. Yes, I repeat, the title will be what not to do in implant dentistry. We'll be having these series of interesting sessions. Dr. Kwan is going to share his experience. He's going to share his failures. I think that's the most important part in implant dentistry, for somebody like Dr. Kwan to share his failures so that you don't have those failures in your endeavors in your implant practice. So join us. Please stay in touch with us. You know we are available always and forever for you. We are called DentistChannel.Online. You can stay in touch with us. We can give you more details about the what not to do session with Dr. Kwan. Remember, it's going to be a long event. We will be starting in the month of January. More information will be given out to you shortly. Thank you so much. We start with the question and answer session. If you have any questions, please feel free to post them in the Q&A box. Thank you. Dr. Kwan, first question from Dr. Hariharan. Dr. Hariharan is asking, which is the website for this implant system?
The website is basically BioHex.com. BioHex.com, but they only have represent part of the product, meaning just a one-piece implant. But my job is not to try to promote the one-piece implant. My job is try to present to my colleagues alternative approach to the current concept, where you have to have the implant, the abutment, and all those things. But from a clinical or practical sense, those current concepts or products or components are really prone to unforeseen complications. But when we have this complication, it means significant impact in our time, our cost, our patient relationship, and problems. Okay, so that's why I feel strongly that first of all, people need to ask themselves, is there a different way of doing dental implant? I know everybody go to implant, doing implant, go to take courses. There are certain commandments or religious rules that you could not change. But I've been there. I follow the rules. I follow their concept. I try their component. I try their innovation for many years until I found out that unless I put the money where my mouth is, I would forever have this kind of problem. Like the first slide that I put up, the quote from Einstein, if you have problem with what you're using, you cannot use the same thing and hope for a solution. You have to find a different way. And I think after 30 years dealing with one component, one implant, and 4 components, one restorative component, and was able to satisfy my patient with daily patient, which I make my monies from, my livings from, then my question began that, do we need all that? Now, do we need a 3D scan? Do we need a surgical guide or printed surgical guide? Do we need a grafting? All these things. So basically, what I have done is the very basic of dentistry. No, anybody doing more than I have done, then their result or their clinical results should be better because they put in more, right? So don't use me as something you attend to. Use me as the lowest denominator because I serve my patient for the 30 years with the 5 components you saw on the behind you, nothing else. If I need anything else to do, then I will let you know. but I have not deviated from that and followed that concept for 30 years and found out that it is sufficient to satisfy my patient. It's a long way to answer your question. It's BioHex.com, and that's our OWeb website. But the other ones, I have, but it's better to communicate with Ruben if you are interested in trying the concept and stuff,
Thank you so much, Dr. Kwan. We move to the next question. The BioHex implant system, which grade of titanium is it manufactured from? Is it titanium grade 4 or titanium grade 5?
I remember when I was doing a clinical study, 1996, when we developed the implant, I basically, without reinventing the wheel, I was using exactly the pure titanium that Dr. Brownamark developed. It's a type 2 pure titanium. Okay, but surely at those days, I remember seeing Dr. Brownamark, Dr. Linkow, Dr. Nisnik were having the same room together, talking about what material will be the best, 4-6 alloy or pure titanium. It's crazy, like to have the biggest implant father in the world and talk about those things. Nowadays, today, the most implant, 90% of the implant was done in 4-6 alloy. So our new implant will be 4-6 alloy, but it's pure titanium that I've been using.
Thank you, Dr. Kwan. We move to the next question. What are the implant diameters and lengths that that BioHex has to offer? So what kind of implant diameters?
Diameter basically are 3. The regular, for most regular single rooted tooth, I use 3.8 with different lengths. They start from 8 millimeter, 10, 12, 14, 16. 3.8, that's the regular daily implant. But with the same abutment, obviously, the same hex. Now, and then realize that we need a smaller profile platform for lateral incisors and lower incisors. So the other one, platform size, is 3.3 millimeters. Okay, but the platform is smaller. So, and that they go from 8 millimeter, 10 millimeter, 12, and 14, 16. So every 2 millimeter up from 8 to 16. Now, when you place implant, I'm sure a lot of you understand, if you don't have stability, you do not have an implant to work with. So stability is the key initial. When you place an implant, they need to be stable. So when we place a 3.8 regular implant, after extraction, sometimes the socket is bigger. So instead of, in order to attain stability, initial stability, so we also develop as a bigger implant, 4.5 millimeter, in case the 3.8 millimeter did not get that stability that we need to engage all the bone in the socket. Okay, so basically, to summarize, the shortest implant is 8, and the longest implant is 16 for the 3 dimensions that we have, 3.3, 3.8, and the rescue implant 4.5. The 4.5 and 3.8 have the similar platform size. The smaller 3.3 is indicated for lateral incisor and that lower incisor. So please do not if you have a case for lower incisor, please do not extract two incisor and place your regular size implant and then the splinter 2 grams. Those are crazy concept. But the reason why we have this implant is that for molar, instead of having a single implant to support a big molar, 1, 6, 2, 6, 3, 6, 4, 6, we usually want to place multiple implants because we have a restorative solution. Okay, so it's better to have more support. Okay, so, but those are different subject altogether. But yes, if I answer your question, there are 3 sizes.
Thank you so much, Dr. Kwan. Thank you for answering in detail. We move to the next question. I think it's a very important question brought by Dr. Mohan. Dr. Mohan is asking, every implant system has its own limitations when it comes to placing the implants in various types of cases. Can the BioHex dental implant system be used for any case and every case?
The short answer is yes. I have for the last 30 years, I just use exclusively the 5 component that is behind your screen, Ruben. For all my patients that coming in requiring dental implant to replace their natural teeth. Okay, yeah, the short answer is yes. So, but do not think as a dentist, we do not need to make those implant parallel. There's a different way to put teeth on multiple implant without having them parallel. You know, like, so do not think like a dentist. I think the biggest problem for implant dentistry is all the dentists, the dental establishment get a hold of this wonderful osseointegration concept and apply dental concept to it. That's why we are forever spinning wheels. I tell you, if you have so many components, so many things you have to do, then 1 implant or 2 or full mouth implant, you're gonna cost people's livelihood. I mean, that's crazy. It's so not such a nice and necessary treatment modality, except it's so expensive that very few people can afford it. It's crazy, and I do not spend all my 30 years, all my professional life, to have it look very nice in few people. I would be so happy that anybody, it's cheaper than repairing your own teeth. I guess that's what I wanted to achieve.
Thank you so much, Dr. Kwan. Before we move to the question and answer, the next question, I am giving an email ID to everyone who has any questions in the near future. If you wish to see this recorded lecture, you can always give us your questions. We would be very happy to give them to Dr. Kwan. And whenever Dr. Kwan is available, we'll request him to answer to your questions. I will be collecting all the answers and we will be giving you the answers to your relevant questions. So if you have any questions, not just about the topics of today, but if you have any questions with regards to implant dentistry in general, who's better than Dr. Kwan to answer to your questions? So if you have any questions, I have put in an email ID and that should be on your screen. That's info, I-N-F-O @DentistChannel.Online. I repeat, info @DentistChannel.Online. So if you have any questions, please feel free to get in touch with us via email. We move to the next question. How do you use this implant in posterior areas with deficient maxillary bone?
Very good question. The posterior maxilla is the most difficult area to treat because limited bone, sinus is there, the bone quality is poor. So if I were to restore the posterior maxilla, let me step back. The number of patients that have deficient maxillary bone is maybe about 5%. Okay, 5%. So those people, you need to do the grafting, the sinus grafting, most popular ones. But for 95% of the people, you can always find bone. Okay, now, but I think this subject we can go to is to the how do you restore a maxillary molar? Because maxillary molar have three roots for a reason, because of what we talk about is big tooth at the hinge area, big load, and that if you put one implant there and put a big crown on it, you're basically putting a potato on a chopstick, which is crazy. So our solution, since we do not need our implant trajectory to be all parallel, that we usually make use of the available bone, mesial buccal root, distal buccal root, and the palatal root. We use those bones, and if usually in 95% of the case, you will find bone there, and put as many implants as you can, because the implant surgically place one implant, two implant, basically you're talking about minutes. But the support and the long-term value for the patient and you will be substantial. I will show you how to do it that will not kill you or your patient. Put many implanting, okay? And that's viewing the treatment planning to minimize your risk, improve the safety, to avoid problems down the road, okay? So then, I don't know if I answered your question. The maxillary bone, because of poor quantity and quality, you need more implant, but you do need a restorative process, efficient process to do it. You cannot put 3 implant in or 2 implant in a molar and do the traditional way. You'll kill yourself. It's not worth it, or the time and cost is so high. It needs to be simple. We can have a subject but let me put it that if you do a root canal on 1/6, do you charge the same as do a root canal on 1/1? Right? You know, so that is doesn't make sense. In other words, we need to challenge all those basic concepts.
Well, with that, we come to the end of the lovely session. Dr. Kwan, thank you so much. It was a pleasure to have you.
Thank you.
We are looking forward to having you soon.
Before I go, sorry, Ruben, before I go, I want to thank you and the Dentist Channel.Online for giving me this platform to share my experiences with my colleague all over the world. I really thank you for doing that and compliment you for that, because if I go up there in a regular meeting convention and say you do not need grafting, you do not need a surgical guide, I will be booted out the door so fast. You know, but truly, what I do, what I say I would do, and what I do not do, I will not ask people to do it, because it will be so hypocritical. But thank you again, Ruben, for a wonderful opportunity. And I was hoping to have more opportunity to share some problems that we have and the solution for it. You know, thank you.
Well, thank you so much, Dr. Kwan. As Dr. Kwan, you've already mentioned, and now that even I have mentioned, you know, we'll be having everybody soon for our much awaited sessions on the topic, what not to do in implant dentistry. Ladies and gentlemen, we're looking forward to having you all for these sessions. We'll be keeping it absolutely free of cost, because Dr. Kwan believes in giving back, and he says that now that he has 30 years of experience, he thought, why not give it back with everyone who's starting their journey or starting their career in the field, the overwhelming field of implant dentistry. So we'll be starting in the month of January. I'm giving you a heads up. January 2021, we start with a bang with a much awaited topic, or however you put it, a discussion on this topic. And this discussion is not going to be a one-way discussion. We want you to come up with your questions to Dr. Kwan. Dr. Kwan will be answering them live, and that's how we're going to keep it interacting. Till then, I wish you a good evening ahead, and we till the next time we meet, I'd like to say goodbye to everyone who's with us. Thank you so much. It was a pleasure to have you.
Goodbye, everybody. Have a good day. Stay safe.
Thank you so much. You too, Dr. Kwan. Stay safe, and looking forward to seeing you soon. Thank you.
Bye-bye.